Evening, everyone. Hi. You're not feeling summer heat, or you're still muted.
I'm so sorry.
Yes, no, you're not feeling summer
Yes, hi, good evening.
heat. Hmm. Oh boy. Hmm. We'll give the others a few minutes.
Yes.
Come on. So you've had a good holiday. I hope a good fourth, and you're ready for Jamaica's.
Oh, the fourth, I was in Jamaica doing a mission
Really? What?
in Clarendon.
Oh my.
Yeah, so I spent my fourth.
Oh my. Okay, wow.
Yes, it was very hot. Is it still hot
Yes,
there?
still hot, still hot.
Yeah.
I mean, I think it's hot everywhere. I was looking at
Yeah,
the
we're in a heat wave started here today.
and I
Yeah.
saw the thing that a feature in Arizona this
Mm-hmm.
morning on the Jamaican news and what's
Yes,
happening there.
all over.
Hmm.
I was in Vere, Rocky
Yes.
Point and Portland Cottage.
Oh, but that's where we were.
When?
Well, we were which Rocky Point? Clarendon?
In Clarendon, yeah.
Yeah, that's where we've been working. That's where Joy has been recruiting people.
Were you at the health center? Were
Close
you
by,
at the
just below the health center. We were closer to the beach front.
Oh, yeah, I was there that week. I think on the 4th of July I was there.
Nice.
We worked at the health center from the health center.
Okay. Awesome. That we are all spreading the word.
Yes, yes.
Yeah.
Mhm.
So we're just about finishing Clarendon now. We've been working there for recruitment for the last few months, so we've kind of come to an end with
Yeah.
most of our efforts. So we're moving to St. Elizabeth.
Okay.
So if you're doing any mission in St. Elizabeth, you must let us know.
All right. We'll do if I know of anyone who's going. Yeah.
Mhm.
Mhm.
All right. Mhm. Mhm. So you can give me 1 minute. Just make sure that our speakers.
Perfect. I think your mic is muted.
All right. And I'm
Thanks,
feeling so
Julian.
good. Thanks, Julia. All right. So good evening, everyone. Welcome again to another live talk. This evening we have a special guest who I'll introduce presently. And of course, I usually start by just giving a little background for those who may or may not be familiar with the project, a little bit about life, what it is that we're talking about. This evening we actually have an interesting topic. It's really about obesity and weight. And the reason why I thought we would focus on it again is really just looking at the reports that are coming back to us from participants in the project. And we realize that there are a number of persons who have weights which are higher than we'd like them to be. And I think we want to make sure that everybody understands what some of these numbers mean, maybe why they're important, and then have the opportunity to talk with one of Jamaica's experts on weight management, Dr. Joy Callender. So I'll introduce her presently. So to begin with, we usually do our little introduction of the project, the live project, for those who haven't been to one of these live talks or who have never heard of the project before. This is a project that we started about 5 years ago, really to understand what was driving the number of persons living with non-communicable diseases. And it's based on work that we've been doing over a period of time. This first slide is really looking at data from the last Jamaica Health and Lifestyle Survey, and that's a national survey where we go across the island, and this was done in 2016 to 2017. The first slide is looking at the number of persons who have obesity, and you'll hear more about that this evening. Obesity, we mean a body mass index or BMI of 30 or higher. This is a level of weight that puts people at high risk for health problems. And if you look at the data that you can see here, as people get older, the proportion of persons living with obesity is higher, and that the women in red have a lot higher levels of obesity than the men who are in blue. And of course, because there's such a high level of obesity, we're also seeing a high level of diabetes. And just the same pattern that we saw for obesity, where a lot more women were affected by obesity, we also see where a lot more women are affected by diabetes, and that the number of persons living with diabetes increases over time until in the people over 75, you're looking at almost half of the population suffering living with diabetes. Hypertension is a lot more common, affecting almost all persons once they are in their 60s. So if you look at the data, while there's not any difference between the number of men and women who are living with hypertension, about 3/4 of the population have hypertension by the time that they're in their 60s. So you wouldn't be surprised that the leading causes of death are really related to the non-communicable diseases. And for those who have been watching the news, you'll have seen the feedback and the concerns that the Ministry of Health and the Minister have had around what's happening with non-communicable diseases locally. For men, apart from external causes, which would include gun violence and motor vehicle accidents, the top causes of death is stroke, or cerebrovascular disease, diabetes, the heart disease, and prostate cancer and high blood pressure are all non-communicable diseases. And these are in some cases related to weight. In women, diabetes, stroke or cerebrovascular disease, hypertension, heart disease, and breast cancer are the common causes of death. And so we really do need to understand what's going on and why is it that we're having so many of these cases in the island. So the life study is a cohort study, and a cohort study is a little different from a number of the other studies people are used to taking part in. So for most studies, you just come in, ask them questions, you visit once, and that's the end of it. Cohort studies, however, are follow-up studies. So once you are engaged or take part in a study, you know we're going to be coming back to you to ask you questions, to see how you have been, to see if you have developed any of these conditions that we're interested in understanding, the diabetes, diabetes, the heart disease, the cancers, and then figure out what is it that is happening which may have put you at higher risk. And this is important because it provides us with the best evidence when we're trying to understand the causes of conditions. It gives us the best evidence that we can work with. So for the LIFE project, we're building on the data on the participants who are part of the last Jamaica Health and Lifestyle Survey. So the data I showed at the beginning was from the Jamaica Health and Lifestyle Survey, and we're going to be going back, or we have been going back to all the communities that were part of the survey across the island. And when we go back into each of these communities, we're looking for participants who are in that initial survey to see if they're still interested in participating and being part of the study. But we're also going house to house in those communities to identify other persons who may be interested in understanding or helping us to understand the causes of non-communicable diseases. And so if you've been approached or are being approached to be part of the LIFE project, you may wonder, what does this study involve? Well, we have our questionnaire. It's pretty long, so be patient with the interviewers as they ask you questions. But these are important questions that we need to ask because for non-communicable diseases, there are so many factors that can result in them. Your family history, where you live, how you live in terms of your exercise, the environment. There are several factors that play a key role in what happens here. And so we ask a number of questions. We will also collect specimens from you. We've been doing blood, urine, hair, nails, and we haven't been doing much saliva, mainly because of the issues with COVID. And then, of course, after collecting these samples, we will be reaching out to you to find out whether or not you have developed any of the conditions that we're interested in understanding: the diabetes, the heart disease, or cardiovascular disease, stroke, or cancer. And so this is what the study involves. And of course, with this information, I think we are hoping that people understand their own health better and their own risks of conditions better. It for us will help us to understand what we need to focus on when we're trying to prevent non-communicable diseases or NCDs, whether it's things in the community, whether it's things that are happening in lifestyle at a particular level. These are all factors that we may need to focus a lot more on to prevent people from being affected by these conditions. And then, of course, the samples that are collected will be very helpful in helping us to understand maybe new ways of identifying persons who could be at risk of cancer, or who develop cancer or heart disease, or maybe even new ways of picking up these conditions when they are present. And these information will work with other information we have so that we can help to prevent and treat these non-communicable diseases better. So this is a list of the investigators, mainly from the University of West Indies Caribbean Institute for Health Research, but we also have two other investigators, Dr. Camille Reagan, who is at the Fox Chase Cancer Center, a Jamaican, and she's also head of the African Caribbean Cancer Consortium, and then a psychologist, Dr. Kimberlyn Ashing, who's at the City of Hope Cancer Center. And so we've been working together with the Jamaica team. Some of them you'll have met already if you're a participant or been part of the studies, and we're hoping that with this information, we can really help to improve our understanding, not just of what causes non-communicable diseases in Jamaica, but in all African descent populations around the world. And of course, this is our symbol, the baobab tree. It's what you see in the slide at the side, and it's one of these trees which is very, very resilient. It grows deep into the ground and has leaves that provide shelter for animals, even when things are hot, like what's happening in Jamaica and in America, as those who were earlier on were hearing about. So we hope that you'll take the time to understand or learn more about the project. And if you're a participant, that you'll continue to be part of this effort so that we can help to turn around what's happening in Jamaica with non-communicable diseases. So with those few words, I'm going to stop my sharing and then sort of give my introduction to our guest speaker. So we're really very pleased today to have with us Dr. Joy Callender. Dr. Joy Callender is a graduate of the nutrition program. from the Tropical Metabolism Research Unit. It's one of the first programs that we had for nutrition training in the Caribbean. And she's a well-known nutritionist, an expert. In fact, I've been referred to her on several occasions. So I told her I'm not asking for a free consult, but I know that her reputation comes with a number of things. She's been working in private practice, and she's also a very strong advocate in terms of health and nutrition, and especially a lot of work in weight management. And today I'm actually pleased that she's here with us, and I'm going to have her focus on one of her areas of specialization, which is about nutrition and weight. And this will also give you an opportunity to ask and have for you answered a number of questions that you may have about being healthy and what this whole issue of weight and weight management is about. So thanks again, Dr. Calendar. I don't feel able to open up your screen. And then I think you should also be able to share screen. I think Janelle would have made sure that you can do that. So welcome to the live talks, and thanks again for agreeing to be a part of the program.
Okay, thank you so much, Professor Tullereed, for inviting me. Talking about obesity, I like pictures. What does it look like? A more modern day version, perhaps. But as you can tell, it's when we have more body weight, more fat than we ought to. Now, there are several reasons for obesity, some of which we're just beginning to understand. But we know that there's a genetic component. Some people are probably born with a higher predisposition to being overweight and obese than others. No, it doesn't mean that those genes need to be expressed. And of course, that is where the lifestyle factors come in, because we can modify the expression of our genes. There are environmental factors, just, how available food is, how often do we see it, how exposed are we? And then there are the psychosocial factors. We do understand that many persons eat in response to stress, or particular emotions. And so if we ever hope to have long-term success, these are some of the factors that we actually have to come to terms with. So there is a definition, and we now regard obesity as a chronic disease. So it's not just a matter of how we look when we go in and stand in front of the mirror and we feel unhappy because there are more folds there than we want to. But from a health perspective, it's something that we actually need to examine. The body mass index is a tool that we often use in order to determine a person's nutritional status. And let me just go forward a little bit. Okay, so let me go back. So as talking about a chronic disease, in one of these slides coming up, we'll see how we can actually calculate this body mass index. And when we calculate it, what does that mean? That number that we come up with, what does it mean? So I started off talking about exposure to factors which make us more prone to weight gain. And the concept of an obesogenic environment comes to mind, so that even while we're driving, I took this picture somewhere in Ligani some time ago, and there was a picture of, it was talking about having just passed a place of eating and pictures of some of the foods available. So even if you're minding your own business and listening to the news, this is something that you might see. We're well aware of the fast foods not all of these are still here, but the fact of the matter is that these are franchise holders which sell fast foods, and so they're available. Couple that with lack of activity, and we can all identify with this, especially during COVID when a lot of persons were working from home. I look forward to actual data which would confirm the impression and early studies that many persons would have gained weight during the COVID era. So what's the meaning of obesity? What are some of the reasons? How do we calculate it? Is it important? And then I want to look at some of the useful strategies and tips that would help us to lose weight and to keep it off. So this is how we calculate body mass index, or BMI. So it's actually your weight in kilograms divided by your height in meters squared. That factor of 703 has to do with just a conversion of units, because here I'm using pounds for weight and height in inches. We are a metric society, but the majority of persons do still understand what their weight is in pounds. So when you calculate that, once you know your weight and you know your height, you can calculate it. You have a calculator, do it while I'm talking. Then you're going to come up with a number. And so on the left-hand side of this slide, we see what the number means. So a BMI anywhere from, let's say, 19 to just under 25 is what we call a normal BMI. And what that means is that your risk for the chronic nutrition-related diseases that Professor Tuller-Reed alluded to just now is at its minimum. You're not likely to get the type 2 diabetes and the polycystic ovaries and the high cholesterol and all of these things. Now, as the BMI climbs higher, then once you're over 25, you're overweight. And once you get to 30, that's when you enter the obesity category. And I beg people not to get caught up in the names. And I know people who hate the word obesity. It's not shaming, it's just a method of classification. And if we change it from obese to something else, it will probably be a word that we all hate just the same. So for all intents and purposes, the term obesity is just used for the purpose of classifying the degree of excess fat or how overweight a person actually is. This slide, you can look on the y-axis once you know your height, and you can look on the x-axis once you know your weight, and where they, so let's say you're 5'6" and you're 175 pounds. This is where they intersect. So that would put you in the overweight category. So that's how this works. And while I'm continuing talking, you can very quickly look at that and place yourself in an appropriate category. Over here would be people who are underweight. Now, just in passing, let me just say that the BMI does have its limitations. Athletes who may have a high body weight, but they don't have much excess body fat, could be placed in an incorrect category. And the elderly, as people get older, they tend to lose muscle mass and they tend to increase the amount of body fat that they have. So those are just two categories that sometimes if we just calculate BMI and we try to come up with one of these categories, there could be error. What are some of the determinants of food intake? Now, there's a popular ad some years ago, and it says taste rules. And that actually came from one of our fast food franchises. And in truth and in fact, very often, taste does rule in terms of what we choose to eat. But I'm going to suggest that all of these ought to be considerations. What is your nutritional status? Are you overweight? Are you obese? Should you be paying more attention to reducing your caloric intake in order to address that? Then there are the dietary guidelines, and we'll talk a little bit more about that as we go forward. But the Ministry of Health in 2015, I think, came up with food-based dietary guidelines for Jamaicans. And so we need to begin to pay more attention to some of those, to those dietary guidelines. I already alluded to the business of emotional eating, and that's just a fact. There are people we sometimes eat because of how we feel, and that has nothing at all to do with physiological hunger. And then persons who have been diagnosed with some of these nutrition-related chronic diseases really ought to be paying attention to their food intake as it relates to managing those conditions. What is a healthy Jamaican diet? In essence, it's a balanced diet. And as a nutritionist, the word balance is one that I always utilize and try to get persons to understand that it's not the one thing that we do, it's the total of what we do that has the greatest impact on our weight and health. So it's a balanced diet with a regular consumption of lean protein sources, healthy and essential fats, vegetables, and complex high fiber carbohydrates. And the carbohydrate foods are the legumes, your peas and beans, ground provisions, your yam, your sweet potato, green bananas, and fruits. I think sometimes we forget that fruits are actually largely carbohydrate foods. So we can quickly take in too much, as wonderful as they are. So this is a picture of the food-based dietary guidelines for Jamaicans. And these are the food groups, the vegetables, the fruits, fats and oils. So fats and oils are included. These are your protein foods, what we call your staples, and so on. And in essence, these are the recommendations. Eat a variety of foods from all the food groups. Eat a variety of fruits, variety of vegetables, include peas, beans, and nuts. Reduce your intake of salty and processed foods. Reduce your intake of fats and oils. Reduce your intake of sugary foods and drinks. And make physical activity a part of your daily life. Now, the Ministry of Health has been doing a big job in terms of the sugary drinks, especially in schools. And the other thing that I'm going to touch on just briefly from all of this is the business of foods which are processed and ultra processed, because more and more we're understanding and seeing that the intake of processed food, things like fries, it's a potato, but it's been altered, lots of additional fat and so on, and the skin has been removed, which is where a lot of the fiber is. And we see an association between the intake of ultra-processed foods and excess body fat. Data from 2008, but I just wanted to show, and this is for Jamaica, you'll notice that fried foods in blue, that's a big chunk of this pie. And then we have stews, a little bit higher, but very often when we buy things like brown stew chicken, it's very often been fried first and then cooked down. Then we have the foods that are steamed. So that's a low-fat method of cooking. And then we have foods that are baked, another low-fat method of cooking. But what this slide is showing is that the way in which we prepare, especially our protein foods, tends to be very high calorie and involve a lot of utilization of fats and oils, cooking oils. Vegetable consumption, much lower than we would like to think it is. Fruit consumption, better than vegetables, but nowhere near the recommendation of a minimum of 2 servings per day of fruit. I thought we can just look at, this is supposed to be a plate, and we want to have, for most of our plate, we want the vegetables, the non-starchy foods. We have to have protein. Protein helps to keep us full. We should have our staples, or the carbohydrate foods, still the most efficient way of fueling the brain, producing glucose. So we need all of them, but the percentages can vary, but this is one aspect of how we can look at a plate and in our own minds, try to figure out how we're doing in terms of our portioning and proportioning. And you notice that there's fruits and there's also water. What are some of the factors associated with obesity? Increased access and availability of foods. And you remember the obesogenic environment that I spoke about earlier. Inadequate supply of fresh whole foods. Not everyone has access to a supermarket where you can go in and get fresh produce on particular days. No, there are always markets, but sometimes in inner city areas, there may not be immediate access to fresh whole foods. I just alluded to the business of processed and ultra processed and packaged foods. And sometimes very many communities don't have access to things like parks. Emancipation Park, I think, is one of the best things we've ever had. It allows people access to safe exercise and physical activity. And of course, we now have a 24/7 lifestyle. Fast foods are open, well, perhaps modified since COVID, but that just lends itself to the business of food being available at all hours of the day. Don't want to do too much. This is just part of what we do now with the advent of artificial lighting. Most people are working longer hours, utilizing screens more. We know that this blue light stimulates the brain. We're not getting enough sleep. And there is an association between inadequate sleep and being overweight. I spoke about the business of available protein. The food substitution list that I use, I've added the business of substitutes so that even people who don't choose to have animal protein can still need protein, and they can access things like tofu. We now have lots of dairy milk substitutes, pseudo grains, your peas and beans, and so on. This business of emotional eating, I often say when I have clients that their first visit, they need a meal plan, they need that guide. But the second visit is perhaps even more important because we have to identify some of these things, non-hunger triggers, some of the things that make us eat. Sometimes it's just habit. Sometimes it's an association between watching TV and eating. But we have to come to terms with these things if we're hoping for long-term success. And of course, always a team approach. Psychologists can play a very important role in this manner. We need to consider alcohol. Here I've just put different types of alcohol and what their calorie count is. Look, for instance, what a shot of rum is. It's about 90 calories. But if you add rum and Coke, then you very quickly go up to 200 calories. So these are some of the things that I just want to bring to mind, that we need to pay attention to whether or not we drink alcohol and how much alcohol we should take. Some general advice: eat less energy-dense foods. There's a difference between eating a potato and eating fries. We want high volume foods. That's why things like salads are important, because lettuce and so on has very little, it may not have a lot of nutrients, but it has a lot of water. And these foods, if you think about things like, especially in the summer when it's so hot, we want to take in more of these high volume water foods, things like watermelon, oranges, cucumbers, because they're very hydrating while at the same time being low in calories. Just a few tips. One of the things that works very well is deciding particular times between which you're going to eat. And at the end of your time, you make sure you try to do things like brush your teeth, so you're done. And mentally, you're signaling your brain that you're not going to be eating for the rest of the night. Many persons snack throughout the night, especially if you're up working or watching TV. Stimulus control. If you finish eating, put food away. Don't leave it for you to go back and have seconds. Don't bake the cake and leave it on the dining table and then wage war trying to prove that you have the willpower to not eat it. A useful thing is going for a walk after dinner, depending on what your housing situation is. That is a possibility. A few tips: seek help. So that's the purpose of a nutritionist, dietitian, joining a support group. It doesn't have to be a formal support group. It might be a group of persons with a similar goal who choose to stay in touch, share recipes, report to each other, be accountable to each other. And so get the kind of support that leads to long-term success. There is physical activity, structured physical activity. And then one of the things I try to encourage people to do is during your day, just be more active. Get up from the chair and go to the next desk rather than using the intercom or the phone. Use the stairs instead of the elevator. Don't over restrict calories, because then you're setting yourself up for more cravings and binging and this kind of thing. And setting realistic goals is very important. That's one of the things that I try to do on that first appointment. What are some of the goals for each individual? There's never one program that works for everyone. There's a role for government and legislation, because very often when it comes to the costs of food, this is where we have to pay attention to. Do our farmers have the capitalization that they need in order to provide low priced crops? Can they get them to market? Do they have the roads so that when they get to the place where people purchase it, the prices are not sky high? So the business of setting policies can have quite an effect on this business of the increasing risk of obesity. So what I'm saying is this what the way that I think we should eat? No, it's not. No, this is a typical Jamaican food that looks like jerk chicken to me. There's rice and peas, but you've got your veg, and you can look at the portioning. Now, this is a much bigger meal. So this may be somebody who, this is supposed to be sweet potato, it's protein, but it's lots of vegetables. So the size of the meal, the calorie count of the meal, the protein content of the meal, all of this can vary, but we end up with a balanced kind of meal. In summary, the obesogenic environment is complex and it requires a multifaceted solution, and very often the coordination of a wide range of sectors and stakeholders. There's the government, ministries, and all of that, school boards, the food industry, all of that. And then perhaps on a more personal level, eat a variety of foods, portion control. That's the name of the game, especially for one of the major chronic diseases, type 2 diabetes. That's the name of the game, and for weight loss. Not so much about determining what you can and cannot eat, but determining how much you eat of the foods that you're having. Avoid over-processed foods. Have protein foods with most of your main meals. We want more water, less alcohol, if any. Make small changes. It's very easy when you're highly motivated to decide that you're going to do everything at once, but you may quickly become overwhelmed. So just calm down and make small changes and be satisfied with those small changes. Focus on health and wellness and perhaps take your mind so much of weight and fat. And always be physically active and let that be a part of your everyday life. And if that isn't a part of the management of stress, then I don't know what is. Thank you very much.
All right, thank you. Thanks very much, Dr. Calendar. It's very interesting. I did end up with to Great River, so I'm going to put that on my agenda for later on in the year.
Yes, yes, yes.
Oh boy! All right. The next thing people ask if that's where the staff retreat will be held. All right. So at this time we open up for any questions that persons may have about weight and obesity. So you can put your questions in the chat, or if you want, you can put down your mic and just ask some questions. I have one, which was just about how people would know whether or not they are at the right weight. You spoke about the body mass index, but I know a lot of Jamaicans don't tend to know how tall they are. Is there another way that they can figure out, whether they are the right weight, or they may be overweight or obese if they don't know their heights?
That's challenging. And so when I assess nutritional status at that first visit, that's exactly what I do: your weight, your height, and I actually do percent body fat.
Mm-hmm.
Now, a lot of people have a sense of what their height is,
Mm-hmm.
If they own a passport, they have a pretty good idea of what their height is. Now, how correct that is, or accurate, is another matter, because my recollection of doing height in a passport office is leaning against a wall and using that to determine your height. And that's the height that sticks in everybody's mind for life. So when they come to my office and I say, no, you're not 6 feet, you're 5'8". A happy camper I do not have. But using percent body fat that's even more difficult to access. I mean, I know people use calipers in the gyms and so on, but actually utilizing height is probably, height and weight is the easiest way. And it's a good proxy for percent body fat.
Yes.
You can look at a person and decide whether they're overweight, but that leads a lot to individual perception. And that is something that you really want to avoid.
My other question is a little bit about, just from your experience, because we're actually thinking about doing something around this area, how people respond to things like, when they hear their body mass index is elevated or their weight. I mean, just from when people are hearing, based on your height and your weight, you're in the obese or overweight category. I don't know, how do people normally react when they get this news? I mean, you may come to them for that.
They hate it. The word obese, public enemy number one. In fact, when I just started as a nutritionist, I was at a medical center, and a member of staff, I saw her, and she never came back. And I got a message, not a message, through a third party, that I used the word obese, and she was so upset. She was not coming back. So I use words at this stage of my life very carefully and cautiously. And as I said earlier, it's not about shaming, it's not about judgment. It is simply determining that you weigh more than you should. You have more body fat than you should. And most people know that. And the question is, how do we go forward to do something about it, rather than getting caught up in whether they're in grade 1 obesity or grade 3? That may determine the course of action. many people that I see have tried many so-called diets and they have not been successful. And so there are many ways of accomplishing success. The first one for me as a nutritionist is lifestyle, what you eat and how active you are. But there are others. There are medications, there's bariatric surgery. The first time, nobody wants to hear the word surgery, but there are people who are doing bariatric surgery. But it usually takes a long time for them to come to terms with that. And lifestyle can absolutely work, depending, I say, it starts in your mind and being committed to focusing on your health. Is it that you've just been diagnosed with hypertension? How do you go about reducing and managing your blood pressure? And when you recognize that exercise and how you eat can make a difference, then that's probably the better approach than focusing too much on, what level of obesity they are.
Mhm. All right. So I have two questions that have come in on the chat, and then there's a hand raised. So we'll start with the questions that are on the chat. So someone joined a little late. Christine joined a little late, and she wanted to know what were some examples of non-starchy vegetables. And she was also asking specifically about ripe banana for people with diabetes.
I thought it was going to be mango since we're at mango season. So non-starchy vegetables are things like salads, lettuce, cucumber, tomato, string beans. In North America, strangely enough, do you know that potato is regarded as being a vegetable? Not so for us. They also regard peas and beans in their vegetables category. Not so for us. We have a particular food group that's actually called legumes. So I usually say to people, you can have as much vegetables as you like. Even pumpkin, which is, I suppose, one of the starchier vegetables, but especially if you have the skin and you just scrub it, because that's where a lot of the fiber is. So the salads, as I said, if you just think about all the vegetables that are available to you, the lower calorie ones, the ones with a high volume of water, those are what we regard as the non-starchy vegetables. In truth and in fact, as far as our food groups go, things like corn, we don't regard corn as being a vegetable. It's actually in the staples group, which is the carbohydrate group. So what we want is balance with more of the low calorie vegetables and less of the, I suppose we would say, the higher starch vegetables. And it's the same thing for the fruits. So things like our OTT apples, I'm thinking here now of things like watermelon. They're going to be much lower in calories, or cherries, much lower in calories than, let's say, mango and ripe banana. But there's no need to exclude those fruits from our vegetables. We manage the portions. And then this becomes even more important for persons with type 2 diabetes. But it doesn't mean that they can't have them.
The other question is I think a common experience that a lot of patients have. So Christine has diabetes and high blood pressure. She's trying to lose weight, but she's not very successful. I know a lot of patients sometimes blame some of the tablets, and to some extent, there are some medications that may make you a little bit more predisposed to weight gain. But I think a lot of people have had a lot of challenges with weight management, with chronic diseases. And I didn't know if you had any tips. She's asking for any tips that might be helpful in controlling her weight or getting her to a healthier weight.
Well, she may need the help of a nutritionist or dietitian. That's our purpose. If you have tried, because what I've tried to go through here, being more active, having more vegetables, using low methods of low-fat methods of food preparation, having a more balanced kind of diet, paying attention to how much alcohol, paying attention to reducing the amount of sugar sweetened and high calorie drinks. If you've tried the usual things and you're still not having success, or you've tried all the different diets and they're out there and many work to an extent, keto diet, intermittent fasting, all kinds of things. If you have not had long-term success, then perhaps it's time to get somebody to help you to put together what works for you. And I spend quite a bit of time talking to persons about what they eat, what they like to eat, what's available for them to eat, what can they afford to eat before actually putting together a meal plan. Sometimes I think when we hear about things like broccoli and cauliflower and asparagus, and we think that we have to eat those things, we have to eat salmon and all kinds of things that we really cannot afford, not in any sustainable way. But maybe if we know that tin mackerel in tomato sauce, that's a source of good calories, good protein, then it can make a difference.
Yes.
So it takes some work to come up with a plan that is suitable for a particular individual. That's why nutritionists exist and dietitians.
Yes, and that's an important point. I see one hand, which is I don't see the name. It's for ZTE Blade. I'm not sure who it is. You want to ask your question?
Well, this is Raquel. Good evening, everyone.
Evening.
I have in a situation here as we speak. I am overweight, and I really need a good diet, a dietitian. That's I can know how to eat. And number two, I'm not able to walk now because the pain, them say it's like it's pinched nerve and it's because of the weight. Or the foot them not I can't move. Especially the right side. No, not the right side, the left side. The foot them did swell the other day, about a week or so ago. But Dr. Gordon did me to get some water tablets and so. But now the pain gets severe. I went to the pain clinic and it's the same thing. And now I can't feel anything. The lower part of my foot from the knee go down. It just not feeling anything there anymore. So I don't know. But what I started to do some green juice, and because them says the weight cause that. I don't know. Can the weight can cause a pinch nerve for the whole side just dead? Because that's what the pain clinic said is pinch nerve. It pinch the nerves, but the hip go down. I can't, and the down that side, everything down there, so that's weak. If when I mind sharp, me drop.
So losing weight would help, but I don't know that being overweight would cause a pinched nerve. So I think there are some medical issues there that would need to be sorted out in terms of whether it's which nerve is pinched, whether she needs physiotherapy. One of the things that sometimes people can do when they have health challenges is exercising in water. But I'm not talking about just going to the beach, because the floor is on, I'm talking about specific classes or with a therapist who would help you to do things in water that you otherwise would not be able to do on land. And those persons exist.
So those things cost, no?
Pardon me?
No, those treatment are expensive. Because what him saying was going to send me go do an X-ray.
Yes.
Same as going send me go. He's gonna send me go do an X-ray, but I just can't understand. Just not me can't move.
Right.
Yeah, so
So Prof, I
yes,
mean, I think
yes,
there are those issues, things that
right.
need to be dealt with.
Right. So I think that whatever is happening with the nerve needs attention, but it sounds like you're in a hospital setting. And I think two of the points that Dr. Callender made are important. One is that sometimes in that setting, you can utilize some of the services that are there. So I don't
No,
know if
no,
that,
not in the hospital. I'm at home.
no, but I mean, you go to a hospital outpatient because you say go to a pain clinic and other things like that. So usually that's at a hospital.
Oh,
So like the hospitals will usually have a nutrition or dietitian
Yes,
that is
yes.
there who could help you with your meal plan. And also the physiotherapy services are sometimes offered at some hospitals, which could help with the pain or even helping you to find some activities. But if there's an issue with the nerve, that still has to be addressed. And so you have to see as they, work through the different issues. You may need a surgery, or also if it's damaging the nerve. There's a lot of things, but the good thing is that if you're in the hospital and you have access to the specialists and the other members of the team may also have access to some of your notes, then it makes it easier for them to plan, what is the best strategy for you and what can be done safely, and that everybody kind of pulls around to help support you, that you can have some improvement in this pain symptom.
it's comprehensive, and them don't have that.
Yeah, so
Because when I
yeah,
go
man,
over
they have a
there,
nutritionist that comprehensive, but you may need to go down to
oh no, oh the
KP
dude,
for the
yeah.
physiotherapist. You may need to
And
go to
some
Oh,
pain
KP.
management,
Right.
perhaps,
Yes.
a pinched nerve can lead to,
Right. Or even see the neurosurgeon, or I
yes,
don't know,
yes.
but
And physiotherapy, if that
yes.
helps.
Yeah. Mhm. All right,
okay.
so we have one more question because we're looking at the time, we're out our welcome. And this is a question which is around, why is it that the fat is always in the stomach area? Why is it? Why is it?
God has a sense of humor. Well, when it comes to women, the business of having children, every time I see a youngster come in and they talk about wanting to gain weight, I said, well, perhaps after 2 children, perhaps we should talk again. Because with every pregnancy, you're expected to put on a certain amount of weight. A lot of people put on much more weight than they ought to. And so with successive pregnancies, that's one reason for weight gain in women of in the childbearing years. And that tends to be on what we call belly fat. And then the business of alcohol too, when perhaps more men, but that very often ends up right on the belly as what we call belly fat. And then there is some people are genetically predisposed to putting on weight on the belly. Some are predisposed to put it all on the on the bumper. Dare I say? Well, most people don't seem to mind that. Some people have a big bosom. So there are many factors. And the one thing that we really cannot do with weight loss is predict or spot manage weight loss. The only thing that can actually do that is liposuction. And that's a decision that an individual can make after they've lost the weight and there's a little bit left where they don't want it. But it usually means losing weight, and you will absolutely lose some from the belly. Invariably.
That's an important point.
And the other thing is, let's say that you losing from the buttocks and you don't want to. So this is where exercise comes in, because exercise is not just about burning calories. It's about building muscle. So when you do specific exercises, you can build those glutes, the muscles, some of the muscles on the buttocks. you can build. So the whole thing put together, and you can perhaps sculpt and get the kind of body that we all want to an extent.
All right. Okay. So thank you very much, Dr. Calendar or Dr. Joy.
You're most
As you're,
welcome. Thank you
as
so
you're,
much, Prof.
as you're well known by your clients. Because I know you bring a dose of laughter.
I thought you were going to say some love, some hate. You know how many times I see persons who have been referred, and they said, Doc, it's a long time I get a referral to come to, like 3 years ago. I said, oh, he just didn't want to see me. But everybody assumes you're going to take away all the things that they love to eat and want to change. People don't like change. None of us does. But I think once we determine that we have a goal, and especially if there's an health issue, then sometimes it's just time to do it.
Yes. As we saw, there's a lot of right now. You mentioned two things about the weight and the need for legislation, and because we're having such a crisis in Jamaica in terms of weight, yes, everybody can make their own decisions, but sometimes having an environment that supports some of those decisions is very good. So even the things around putting less sugar in juices and regulating what people have is an important part of helping to manage weight, that you're not always fighting the environment, but the environment can give you some support too. And I like your point about nutritionists. I think we need a lot more in our public system and other centers, because we definitely could benefit. A lot of people could benefit from that
in
level
terms
of
of
support.
access.
Yes. So I know you'll continue to be an example and an advocate for your colleagues.
I try.
All right. So thanks everyone. Thanks, Dr. Calendar, especially for speaking. We enjoyed your presentation. It's on YouTube, so people will be able to look at it if they missed the session. You've been able to answer a number of questions. I'm sure this will be shared in other fora. Thanks to others who helped to organize today's meeting and disseminated it. Janelle, who has been monitoring us and making sure that things went smoothly, and also to the participants, the persons who came out this evening. Thanks for joining us, and thanks for your very important questions, which have really helped to highlight a few important points that we need to understand about weight and weight management. So we won't have a talk for August. You get a little break, but we resume in September. And of course, you can look out for the usual reminders and notifications before then. So all the best. Have a good night. Have a good Independence for those in Jamaica. And remember some of the tips that you got from Dr. Calendar. So I'm not saying you must only have rum, but maybe rum and Diet Coke. I'm not going to advocate that. All right. So good night, everyone. And thanks again for joining us. Take care.